Yeah, I'm here. Yes.
So I think we're gonna divide this scenario between yourself and Brandon
Okay.
because Brandon had a very short scenario. So Brandon, please get ready. You're gonna start. You're gonna take half of the questions as well. You have a
Sure.
28-year-old male patient who was admitted under orthopedic team with crushed injury. The blood showed achy eye, and urine dipstick showed some blood as well. What are the causes of these findings?
Um, so because of release of myoglobinuria causing damage to the kidneys.
Yeah, but you want to give me the name of the cause at least. So what's the name of this condition?
It's actually a crush so compartment syndrome.
So crush injury or rhabdomyolysis, not necessarily a compartment syndrome. All right. What's the likely pathophysiology of the current presentation? I think you mentioned that the
Yes.
myoglobin release,
Yes,
which will
which causes damage to the renal tubules.
what is damage to the renal tubules? What is it called?
Acute kidney injury.
Not really. It's acute tubular necrosis,
Acute tubular
right?
necrosis.
That will lead to acute kidney injury, of course, but to be more specific, the myoglobin will deposit into the tubules, leading to necrosis. So it's called acute tubular necrosis. What's the clinical presentation of compartment syndrome?
Patient presents with pain which is out of proportion. Apart from that, he'll have the leg will be pale. It could be paresthesia, loss of pulse in the last phases, and there'll be passive stretch pain as well.
All right. So limb pain, paresthesia, pulseless, and also sensory loss and paresis, etc. Okay. What's your initial management?
Um, First, you have um, to check the compartment pressure. Like to check the compartment pressure, um, and
So first thing you're gonna do with patient in severe pain,
pain. Yeah.
screaming out of pain, you're gonna stick a needle into your calf muscles to connect it to a manometer to measure the intracompartmental pressure. Do you think this is reasonable?
First thing is we have to give him adequate pain relief. Sorry.
Yeah, I mean that's one thing, but not everything. So the initial management, again, this is a critically unwell surgical patient. You
Okay.
would like to follow an AT approach.
Mm-hmm.
The most important point here is your C.
Okay.
You want to insert two or cannula, take all the labs, start resuscitating your patient, making sure you're getting them ready for surgery,
Mm-hmm.
examine the lower limb quickly. If you establish that this is compartment syndrome and the patient has been acute kidney injury, you want to resuscitate the patient to prevent further kidney injury. All right?
Mm-hmm.
Get a bladder scan, insert a catheter. Once you've done everything, you want to escalate immediately to theater team for this patient to have what operation?
Come fasciotomy. You have to plan for a fasciotomy.
Have to plan for a fasciotomy. So you want to speak with the senior registrar in orthopedics, the anesthetic registrar, the theater team, theater coordinator, and book the patient into theater list. All right. So it's really important because this question, at least you will answer it in this exam at least 5 or 4 times in your actual exam, and
Mm-hmm.
you will study it at least like maybe 20 times.
Okay.
So you want to like master the answer to this question because it's generic. You
Mm-hmm.
have a patient with significant severe abdominal pain after left hemicolectomy,
Mm-hmm.
and the abdomen is tense and tender. What's your management?
So similar again.
You wanna do a full A2E approach,
Okay.
okay?
Focus on.
Uh, so this patient is critical and well. In the C, insert 2i4 cannula, take some blood, start resuscitating them, examine the abdomen, and also make sure that they are ready for theater. Get clotting, Grubin screen, consent them for surgery with the which is abdominal exploration. Escalate to registrar, escalate to the anesthetic. It's the same answer. There is no
Okay.
significant difference.
All right.
All right. So Brandon,
Yeah.
you have a patient with altered sensation and a sensory motor deficit. How would you diagnose compartment syndrome?
Okay. Compartment syndrome will be diagnosed with intracompartment pressure greater than 30 millimeters of mercury, or it can be a clinical diagnosis.
Would you do this in every single patient? Would you measure intracompartmental pressure in all the patients?
No.
So you want to say that compartment syndrome is mainly a clinical diagnosis
Yeah.
based on the history and the presentation. An additional investigation that can be done is measuring the intercompartmental pressure. All right.
Okay.
So instead of just saying the measuring the intercompartmental pressure, you can also say that it's mainly a clinical diagnosis. How would you treat compartment syndrome? We already said that, right?
Yeah.
What's the answer?
So, okay, so we'll treat compartment syndrome by following the CRISP protocol in an ATE manner, ensuring that the patient is stable and focusing on the circulation. We ensure the patient is adequately resuscitated with IV fluids, and we'll send off some bloods in the meantime, full blood count, use these creatine kinase, in addition to put in a catheter. In terms of the relieving the compartment syndrome, we do a four compartment fasciectomy and in theater, where the orthopedic registrar anesthetics would be involved.
Yeah. So fasciotomy is the answer here, but well done that you went through the whole ET approach. But of course, if the whole scenario was for yourself, you don't have to repeat it. You just want to
Okay.
say fasciotomy. Okay. Where will you do your incision? For which compartment? The patient has the compartment in the calf muscles. So what are you gonna do?
So it'll be the two incision four compartment fasciectomy. One incision will be anterolateral to relieve the anterior and lateral compartments.
How many incisions are you gonna place?
Two. One will be anterolateral and one will be medial to relieve the posterior.
So basically, the key point here that you want to decompress the four compartments. All right. So you're gonna do. I'm not sure if you can hear me. I think my internet is unstable. But can you hear me now?
Yes, I am.
Yeah. Good. So you want to decompress the four compartments so you can do 3 or 4 incisions. Okay. How will you consent the patient for a fasciotomy?
Okay. I'll explain to the patient the urgency of the emergency of the situation and the complications that can happen if a fasciectomy is not done, in terms of patient can lose a limb, and even it could cause systemic effects in terms of kidney failure and other severe effects on the cardiovascular system. In addition to that, I would let them know about possible complications of this surgery, where you could have neurovascular injury, even it could have potential for abnormal scarring, muscle necrosis, and possible amputation in the future. If the patient is coherent, you would do an adult, we could do the consent form type 1.
Yeah, that's right. Well done. So you want to mention the type of the consent and the risks and benefits of the operation. Can you explain to me why this patient developed acute kidney injury?
Okay. So with compartment syndrome, it can have sequestration of fluid, and it can cause a prerenal cause of acute kidney injury, in addition to toxic effects of the myoglobin, where it could be precipitated within the tubules of the nephrons, causing direct toxic effects on the tubular cells, causing acute tubular necrosis. Both effects could lead to acute kidney injury.
Yeah.
Yeah.
So it's mainly like